I would like to thank our distinguished guests, panelists today, and I will allow Sophie to introduce Mary and Suzanne, and thank you very much. We're very honored and delighted to have you join us. I would like to thank Sophie and her team for their work and our faculty panelists as well today. Vice Dean Rhonda Maniveau for her work also in terms of presenting, as well as Dr. Smeltzer and Dr. Donahue. And I really also would like to thank Ileana Bautista from our development office in terms of her outreach efforts. For those of you who are watching not live, joining us, I hope you will share all of our very interesting series of grand rounds this year with your friends and colleagues. I also would like to give a big welcome to our student guests, community members, and alumni. And I'm really delighted to be able to appreciate and learn from your wisdom and teachings that you'll give us today. Thank you. And so let me turn you over now to Dr. Marie Charles Lords, who will be Marie Lord Charles, who will be
Marie Lord Charles.
Our introductions today. Thank you, Dr. Charles.
Okay, good afternoon, everyone. And thank you, Dr. Tai, for spearheading the Grand Rounds series at the College of Health Professions. I want to thank everyone for taking time out of their busy schedule to join the conversation. This is a conversation, and we're hoping that all of you will be participants. Health inequities affect all vulnerable groups, but more so those who don't have a voice. One such group is the disabled population. Disability has been around as long as human existence. It comes in all shapes, and it does not discriminate. However, how disability is perceived depends on environment, culture, religion, ethnicity, and the list goes on. For example, we've all heard of the eugenics movement, its atrocities, and how it affected and still affects policies related to vulnerable populations, such as persons with disabilities. But there's a silver lining. On July 25th, 2020, we celebrated the 30th anniversary of the American Disabilities Act. And to get this law on the books, it took a lot of effort. It took a lot of efforts. And it's going to take even more effort to make sure that the laws are enacted to benefit the people they were purposed to serve. And as we all know, institutional culture is difficult to change, and healthcare institutions are no exceptions. For my own work as a researcher, I found the disparities in healthcare received by the disabled blatant. As a caregiver of an adult with intellectual and developmental disability, the spouse of someone suffering from epilepsy, I can attest that there's much work to do. More disabilities, the stories are endless. So where do we start with the quest to improve healthcare for people with disability? To the providers. And this is where we are now. This is why we brought these panelists together. Dr. Smeltzer is an expert. As I was doing my research on developmental disabilities, her name, I became very familiar with her name. She's one of the few researchers in the United States doing work with people with disability, notably those with intellectual disability. We tend to find more of such researchers from outside the United States. And Dr. Smeltzer is a professor at Villanova University, has received numerous awards for her work, and she's a fellow of the American Academy of Nursing. I'll let Dr. Smeltzer tell more about herself. And we have Dr. Donahue, who's a behavioral psychologist, has worked for AHRC for years. And AHRC does have a history with Pace University, notably one member of the Seidenberg faculty has done a lot of work with the computer students with AHRC. And of course, we have Dr. Manoval, well-known Villanova alum. And Dr. Manoval is more responsible for integrating, or rather responsible for improving the education for the education of future providers with disability. So I'm gonna start out without further ado. Let me start out with Dr. Smeltzer. And Dr. Smeltzer, you will tell us a little more about yourself. Your work highlights the need for equitable care for people with disabilities. Can you provide us a broad definition of disability and expand on the major obstacles faced by this group when they navigate healthcare systems?
That's a loaded question, Marie. Actually, you sort of led me right into it since you mentioned the ADA, the Americans with Disabilities Act. One of the things that I usually say is the Americans with Disabilities Act was passed in 1990. It has yet to be enacted, at least fully, which is certainly one of the issues. There are many definitions of disability, and they differ because of the use of them for various purposes. One of the things that I have heard is that there's something like 120 different definitions of disability in the federal government, which could be a function of the government, or it could be, an indication of the diversity of disability, or it could be both. I want to read to you the definition of disability provided by the Americans with Disabilities Act, because I think it is the one that those of us in the United States need to be aware of. We need to understand it. We need to understand its limitations as well. So this is what the ADA says in terms of what disability is, and I'm going to read it so that I don't get it wrong. The ADA defines disability as a physical or mental impairment that substantially limits one or more major life activities, a history or record of such an impairment, or the perceptions of others of having such an impairment. The ADA identifies or categorizes disability into 4 major categories, and let me just list those, and then I'm going to explain a little bit. Visual impairments, hearing impairments, motor impairments, also called physical impairments, and then cognitive impairments. And cognitive impairments includes a lot of subcategories: psychiatric mental health disorders, neurodegenerative disorders such as dementia, and intellectual disabilities. The ADA, which was enacted, was passed, not yet enacted, in 1990, was the first federal civil rights legislation to address health inequities of individuals with disability. What the act does is to prohibit discrimination on the basis of disability, and this includes healthcare. The ADA requires that healthcare entities provide full and equal access for people with disabilities. That means reasonable modifications or accommodations, and that, as you can imagine, is defined differently by different people. Effective communication, huge issue, and accessible facilities. Those are the things that the ADA requires of healthcare providers or entities. That could be an individual office, it could be an imaging center, it could be an entire healthcare setting, huge healthcare setting. But one of the things that the ADA definition does not do is to talk really about a corollary issue, which I think is equal in importance. And that is that it's not just the disabling condition or the disorder that we need to be concerned about as healthcare professionals. We need, I think, also to be concerned about the life experience of the person with a disability and their day-to-day experiences. You know, somebody has a disability and, you know, they have difficulty getting up in the morning, they have difficulty getting fed or getting their own food. You know, if they are not given adequate attention, you know, they can get into all kinds of difficulties. So the things that we as healthcare providers need to do goes beyond addressing the underlying disabling condition. And I think the other piece that is not addressed, although if it's addressed negatively, is the issue of quality of life of individuals with disability. All too often, quality of life, and this applies in other places and other situations as well, people tend to define or describe somebody else's quality of life. Cannot be done. The only person who can determine somebody's quality of life is that person. So there are a lot of people who make judgments about individuals who are a little bit different, and say, well, that person doesn't have a very good quality of life. Well, you can't say that. You have to ask the person. And I think one of the places that has come up recently is related to COVID. There have been, when there was the very dire early circumstances, where there were questions about, well, who's going to get the ventilator? We only have so many. Who's going to get the ventilator? There were some people who were immediately knocked off the list. They tended to be people with disabilities because they don't have a good quality of life. Wrong. Something we need to rectify and do something about. So there's the ADA, and then there's what really happens, on a day-to-day basis. So what happens in reality? Well, there are lots and lots of barriers to quality healthcare. Some of them are pretty obvious, lack of accessible healthcare facilities and accessible equipment, such as tables, exam tables that go up and down. Scales that are used to weigh people. One of the things that's usually startling to a lot of people is the realization that women who are pregnant and have a physical disability can go through an entire pregnancy without ever being weighed. It's incredibly important as a monitoring device in pregnancy. Why doesn't it apply to women with disabilities? It doesn't, because they can go, they can go not just through pregnancy, but they can go for 20 years without ever being weighed. And that has lots of implications. Some of the other issues, relate to accessible transportation. In order for people to get to imaging centers, they need transportation. And we do not have in the United States a particularly accessible system. We have one that needs considerable improvement. But there's a whole set of other issues that are environmental, but they also emanate, I think, from individuals. And that has to do with the lack of knowledge on the part of healthcare professionals about disability. I don't know about you, those of you who are health professionals. I know that when I went through my educational program, and I've been through a lot of educational programs in my lifetime, disability was not taught. We were taught about disabling conditions, which is not the same as the day-to-day experience of somebody with a disability. That does not occur just in nursing. That occurs in medicine. That occurs in dentistry. And believe it or not, that also occurs in OT and PT. I mean, they do talk about disability in OT and PT, but it's from the perspective of something needing to be fixed. And as we all know, some disabilities are not fixable. So what are you left with? You shouldn't be left, or they should not be left with, well, there's nothing we can do for you. There's a lot we can do for them if we pay attention. So the knowledge on the part of healthcare professionals about disability is huge. That's a huge issue. There are healthcare professionals who believe they know about it already, that they already do it, provide accessible and quality care. The reality is, if you ask the people with disabilities, they will say, no, I don't get the kind of care I need or the kind of care I deserve. So there are negative attitudes and there's a lot of bias. lack of comfort on the part of people with disabilities, lack of comfort addressing the healthcare needs of people with disabilities on the part of healthcare providers. I didn't say that right initially. So just to give you another view of this, much of my recent research is focused on pregnancy. You can imagine, since I just used the example of not weighing women with disabilities. So I have focused on pregnancy and women specifically with physical disabilities about what are some of the barriers that they encounter. Negative attitudes are a big barrier. Many people, including healthcare professionals, think that women with disabilities shouldn't have babies. They shouldn't be mothers. And if somebody is interested in pregnancy and interested in having a baby, if somebody comes into an office already pregnant, too often, let me put it that way, the first bit of advice and interaction with the woman with a disability is to ask if she's there to terminate her pregnancy. This may be a well thought out, highly valued and highly planned pregnancy, and yet she's being asked if she's there to have her pregnancy terminated. That's not uncommon. Some of the other issues, women with disabilities often report that healthcare providers don't know anything about disability in the context of pregnancy, or pregnancy within the context of a disability. The women themselves typically want to know about, if I have a baby, what do I need to expect in terms of my disability, in terms of what kind of care I'm going to get, and they don't get answers because there's very little research on that topic. And healthcare providers often believe that they already know. One of the things I think is really important is for us to consider the people with disabilities as the experts. If somebody's lived with a disability from the day they were born, they know a whole lot more about the disability than you or I do, or anybody else for that matter. And we need to listen to them. And often that doesn't happen. Another issue is that women with disabilities who have babies and young infants often fear losing custody of their children. Why? Because they have a disability, not because they do a bad job of caring for their infants or their children, but merely because they have a disability. And one of the things that I think is really important for us is, because of that fear, they tend not to ask questions. They tend not to reach out, because that might be considered by a healthcare provider as, well, why doesn't she know that? We need to look into this. Everybody knows that. Why doesn't she know that? And pretty soon, the people with disabilities just quit asking questions, pregnant women with disabilities. So the barriers are numerous that people with disabilities face across the board. The effort on the part of PACE to address this issue, I applaud wholeheartedly, and we'll leave it at that and see if there are questions later on. Thank you, Marie.
Thank you, Dr. Smeltzer. You really brought a side of it that I had never thought of, the fear of being pregnant, the risk of losing your child being taken care of, or being taken away from you just because you're disabled. Thank you for that point. Dr. Donahue, in your role as a practitioner and from a multidisciplinary perspective, can you tell us about the role of AHRC in caring for people with intellectual and developmental disabilities?
So AHRC is one of quite a number of nonprofit providers in New York City that provides really a wide array of services for people with intellectual and developmental disabilities. There's a wide array of services, and there's also gaps in services for many people. And one of the big gaps is the intersection with healthcare. So services vary depending upon the age of the person, depending upon the level of disability and needs, and depending upon preferences of the person and the family. So services can begin as early as birth, with even an at-risk infant toddler being eligible for early intervention services. By the age of 3, children diagnosed with a disability are eligible for preschool services, often provided through agencies such as ours and increasingly more through the DOE. Within those preschool services, the approach is really holistic. So not only is the focus on education, but also really looking at whether the child needs speech therapy or physical therapy and occupational therapy. So really looking kind of at all of the developmental needs. By kindergarten age, so by 5 through 21, that young person would be served somehow through the Department of Education. They may go to a DOE school, they may go to a school such as ours, where it really specializes in a particular disability for high needs students. Often what we find, though, these families, in addition to the school services available, there's also services available through AHRC and other agencies, such as respite for families, some in-home services where a direct support professional can go into the home and work on habilitative goals and support the family. The system, both through the education component and through those other services, can be hard to navigate for families, especially families where maybe if English isn't their primary language, or if they're newer to the country or our systems. One of the impediments, especially for children with much higher needs, is a lack of healthcare providers who really specialize in children with disabilities from a diagnostic perspective and from a treatment perspective. We find families of our school children with really complex needs, so families where they have a child with a complex seizure disorder, or where the complex presentation of how much is what we're looking at autism, and how much is attention deficit disorder, and how much might be something else. And to get that evaluation and treatment from a medical provider is surprisingly difficult, even in New York City, where you would think it would be pretty readily available. What we find is families that have more sophistication or more means can really access high quality evaluations and services for these children. And families in more underserved neighborhoods or more underserved demographics really struggle, including with our help. There's actually a shortage of providers, especially depending upon the person's medical insurance. So if we're relying on Medicaid as the payee, the quality of those services for children can really not necessarily be the best quality. The other big gap for children is we often find out children with autism, especially our younger children, have such food selectivity issues that we have children who are really undernourished and may only eat, French fries and French toast, for example. And the need for specialty feeding programs, I believe St. Mary's in Queens is probably one of the only programs in New York City and has a really long wait list. As the children transition to adulthood, the services then are funded through New York State. So they're funded through the Office of People with Developmental Disabilities, or OPWDD. And really a broad array of programs, but again with some gaps and real challenges negotiating. So through that system, a person can obtain a residence or a group home, and with the level of support based upon need. They could obtain housing support. They could obtain vocational or job training and placement, recreation services, in-home services, day program services, all of which we provide, and most agencies similar to us provide. Where we find the gaps even within that system tend to be, again, with people with the most complex needs. For example, there's very long waiting lists in New York City for people requiring, looking for a residence, a group home, especially if the person has accessibility needs. So if that person needs an accessible house without stairs, it's so difficult in New York City. If a person has more than one disability, so a person has autism plus a profound hearing loss, finding appropriate services and appropriate staff who can manage both is often a real gap for the person. People with complex, challenging behaviors, there's gaps in supporting and finding services, and some of that has to do with funding issues. In relying on government funding, which the entire adult service system relies on, it makes it very hard to match funding to the person. So it's a one-size-fits-all. So, a lot of providers struggle in really serving a number of people with high support needs just in terms of financial viability. Also a gap in serving senior citizens because of the complex medical needs. So we support people, the oldest person that lives with us is well into their 90s. So a phenomenal job in supporting people's medical needs, but a lot of struggles in finding integrated healthcare for them and providers who can address those geriatric needs and the mental health needs and the developmental disability is, again, a real area that's lacking. As a provider, and really in all of our services, but especially in our residential, where we support people at home, we're very involved in people's health care. We're very involved in looking for services, overseeing services, looking for integrated services, and a real tremendous challenge in finding providers. I think a lot of providers view the people we support as either they don't feel they have the expertise and they don't want to get involved, or they feel it's too, takes up too much of their resources because the appointments are longer, they're dealing with often sort of multiple layers and talking to staff, they're having to coordinate with other providers, so many just feel that it's more resource than they can provide. Especially specialty, well, actually even primary care, but also specialty dental, OB/GYN are just so hard to find. Increasingly psychiatry, and I know there's actually a shortage of psychiatry for even the general population, so when it comes to people who are more complex to treat, it's a major challenge for us. And interesting, Dr. Smeltz's comment about COVID and the looking to, some talk about rationing ventilators. We actually had that very experience. A young person, but Down syndrome in the early days of COVID, and we really had to fight for the ventilator. So I guess the quality of life view and people who are not really within this disability realm sometimes misjudge the value of the people we support and the quality of their life.
Thank you, Mary. Thank you, Dr. Donahue. I'm listening to Dr. Donahue telling about all the resources. I invite you in the audience, if you know anyone who needs resources, please share with them. There's a YAI, I've interfaced with YAI, Center for Family Support, numerous. And sometimes parents, caregivers will receive a referral from a friend sooner than from somebody else. So please free to access the services and the information, and please share, because really parents with or caregivers with a person with disability, especially intellectual and developmental disability, they're very isolated. I had a participant with a Down syndrome brother who was 60 years old. And she said to me, a participant in my research, she said to me, you know, people look at him as if he should not be alive. He should not be 60 years old. So if you can come along with people who need services, please do. And Dr. Manovo, Vice Dean Manovo, how can we as educators prepare future providers to care for people with disabilities after hearing all this?
Well, thank you, Marie, for that question. I think I, like many educators, am learning about how to do this work, effectively from experts. And every time I'm in the room with Dr. Smeltzer, Mary, other people from our advisory committee, Marie, etc., I learn more and feel more urgency to do this work in this space. So, I think first we need to ask the question, how are we addressing the needs of people with disability in our respective curricula? Is it there? And if it is it there by intention and by purposeful design? For example, having been a nursing educator for 30 years, reflecting on my experience, it seems that in many programs, disability is found kind of tucked away within the context of other major content areas. For example, if you look at a nursing pediatric textbook, even today, you'll find definitions of various forms of intellectual and developmental disabilities, autism, Fragile X syndrome, but very little content that speaks to how to meet the healthcare needs of these children and how to develop a plan of care for the child and for the family. And more importantly, there is little attention to any content that speaks to their needs as they age. Children with disability become adults with disability. Another example is really around, there's been so much conversation here today about the American with Disabilities Act. Do we intentionally address the ADA? The ADA is one of America's most comprehensive pieces of civil rights legislation that prohibits discrimination. What do we and our students know about it? And do students understand how they, as providers, are responsible for ensuring their patients and people in their communities with disabilities have full access and are treated with respect? Do our students know what the standards are? Do they know how to help people navigate the system for services? And what they should demand to be available to ensure access and respect? As providers, will they be advocates for social justice for people with disability? Sorry about that. And do they understand the responsibility that they have for ensuring that their patients and people in their communities have full access and are treated with respect? It was not that long ago that textbooks and subsequently our teaching did not address cultural, racial, ethnic, gender, socioeconomic differences in the care of people. And when they did, it was often through stereotyping those differences. Disability education is part of our work in diversity, equity, and inclusion. And what we know about actualizing DEI is that work must be intentional if it's to be successful. So back to the original question, how do we as educators prepare future providers? A few thoughts. I would challenge us to be self-reflective as to our own understanding as faculty. What we need to fill in our own gaps to our own understanding. And as faculty, we need to look at our textbooks, our resources, our program outcomes, our curricula, our individual courses to assess, and if needed, to revise to be inclusive. We need to be clear on the competencies around and in this space that students should have and must have in order to graduate from our programs. And I think that we're very fortunate in the LSN to have received a grant from the Yucatan Foundation to assist us in this work. In addition to supporting curricular efforts, the grant funds the construction of a state-of-the-art ADA compliant examination rooms in our simulation centers on both campuses, which will benefit all of our CHP students. To me, this is a visible and tangible way to demonstrate to our students how important this work is and to help them to be aware that the standard of care is set and that they should be demanding this standard of care in every practice setting that they work.
Thank you on that. Thank you for bringing in the importance of advocacy as we educate our students to provide healthcare. Advocacy is an important piece. So back to Dr. Smeltzer. I see a lot of good comments on the chat. So we're going to leave space for conversation. But Dr. Smeltzer, as a researcher in the field of disability, how has things changed and how do you foresee the next 5 to 10 years? What could you predict for the next 5 to 10 years?
Things move very slowly, unfortunately. One of the things that's interesting is about every 10 years on the anniversary of the passage of the ADA, editorials and commentaries appear in several different journals, New England Journal and JAMA, and I can't remember where else they've been. And they often, sort of look back and say, okay, this is where we started, 20 years ago, 30 years ago, et cetera. So where are we now? And the report card basically is mixed. And it says, in terms of the environment, we've made some progress, a good bit of progress. We have curb cuts, we have accessible transportation, we have this, that, and the other thing. But the report card on healthcare is not as positive, so we haven't made as many strides as we could or we should. So we still have a lot of work to do. And I think as time goes by, looking about where we are now as opposed to 5 years ago, there is, I believe, a greater emphasis, and I think this is going to move forward, a greater emphasis on healthcare professions doing something about this huge gap in their education of, the future generations. There seems to be sort of almost a growing competition, to see who can get to it first, which is good. Particularly in terms of developing materials related to intellectual and developmental disabilities. I think competition, as I say, will sort of push that forward. One of the other things that I think is moving slowly, but maybe it's picking up a little bit of speed, is the effort to get accreditation, licensure, and certification standards lined up so that programs have to display in their curricular materials an effort, to make a difference. I know that already is the case in dentistry. And recently in talking to, a dentist about that, he said, well, this is what it says on paper. This is what it looks like in reality. It's mentioned, and every school can do it differently. And in his particular school, And this is a dentist who has I think she's a 35-year-old daughter who has Down syndrome, so this is really a major thing of importance to him. But he said that their whole effort seems to depend on one dentist who invites the dental students to rotate in and out of his clinic, where he sees individuals with developmental disabilities. What's going to happen when that person's no longer in practice? That's a big concern. That's a huge concern. There was something else I was going to add to that. Education, healthcare provider. Oh, I know. The other thing I was going to say, talking about standards. The essentials document, which all of us are pretty familiar with in nursing, that came out relatively recently. Just a sort of a short story on something that has sort of happened over time. I happened to run into somebody at the academy meeting a couple of years ago, and I hadn't seen her for a while, and she recently retired from a deanship. And I said to her, "What are you doing now?" And she said, "Oh, what I'm doing is I'm working on the new essentials document." And I thought I had struck gold, because I thought, okay, I'm going to tell you what needs to be done. So I did. I told her what needed to be done. You've got to get disability in there. And then I saw the document when it came out. And some people have looked at the new essentials document and have said, well, it does address disability. And my response is, it's something like a 21 or maybe it's a 41-page document. The word is mentioned 4 times, maybe it's 5 times, but it's not mentioned very. And when it's mentioned, it's between disease and death. That's inadequate. That is not good enough. We need to do something about that. Recently, again, a little bit of background. I have recently retired from Villanova, although I'm still involved in a grant that Villanova has, which is related to disability. And so I'm not there full time. And, with COVID, I'm not there much at all. But they are in the process of doing some undergraduate program revision in order to make sure that what they're doing is consistent with the new essentials document. And so I, got on the phone and I said, we got to make sure that disability is in there. And they sent me the document that they were working with, which is a framework. And it had, it looks like it's the essentials document, but put in some sort of a chart. And they considered disability as adequately addressed in DEI. And I said, yes, it's supposed to be, but if you do not use the word disability, it will disappear. And they decided that I was right. And they have now added that word, explicitly. Now, it doesn't mean they're necessarily going to do what I want them to do, although I'm going to be on their backs to do what I want them to do. But at least the word is there now, because even something like that, the insertion of one word can make a huge difference. If it's not there, it will totally and completely disappear. And so I rued the day when I saw the essentials document and said, no, didn't do it, didn't make it. And I would add that some of us actually sent the, that came out of AACN, sent the AACN wording to include based on what we saw in the draft document, and they did not make the appropriate wording. So as far as we were concerned, they failed the test. But it's got to be visible. It can't be something that is left to chance. And one of the things that I've often said is, it's probably a pretty selfish reason for saying that we need to address people with disability or the topic of disability going forward. The likelihood of all of us having a disability at one time is very, very, very high. I want the future healthcare professionals to know about disability when I get there. That's a selfish reason, but you know what? I'll take it. That's my response.
Thank you. Yeah, we want to make the care better, not just for others, but for ourselves as well. Dr. Donahue, in terms of health equity advocacy, how can the community become an ally?
I think the most important thing is to really get involved in advocacy. So for people with disabilities as self-advocates, for family members, for professionals, because so much within the realm of intellectual disabilities is driven by government. So much of the advocacy has to be there in terms of funding and quality of services. So to know the issues, to join advocacy groups, often there'll be a call for to contact your legislature or to write letters. And sometimes it's overwhelming because there's so many requests for that, but often it's in response to a threat to really cuts to vital services. Like, for example, preschool special education tuition is so low through state ed that most of the preschools serving severe disabilities are in danger of closing in New York City. EI has had so many funding cuts, early intervention, that it's really hard for families to find a center-based early intervention program. So the need for advocacy is so related to what's happening legislatively. So really to join rallies, to know your legislators, to know the issues from a reliable source, and then to know really the position of who we're voting for, especially on a local level, because a lot of this is driven through the New York State legislature. And if on a local level, if those representatives get enough kind of pushback or contact from their constituents, can really have an influence there. And, you know, this panel and this connection with nursing education, I have to say, is so important because we experience there's such a nursing crisis for nurses who are willing to support people with more severe disabilities. And if anything, in my experience, I've actually found we've gone backwards in terms of healthcare equity for the people we support because of a lack of providers. 10 years ago, we probably had less of an issue finding primary care physicians and specialists than we do now.
Wow. Oh boy, there's so many avenues that, where we can be involved. It's 4:14. I don't want to go over time. I think we need to go into questions. Sophie, are there any questions on the chat we need to address?
Yes, so thank you for wonderful comments and questions. I'll start with the most recent one from Ida Oscar-san. Thank you for wonderful recommendation and discussion. Completely agree that disability inclusion in nursing education is missing. Maybe we are touching on the medical piece, but certainly not on how social, systemic, economic, and cultural factors impact the health and functioning of people who experience disabilities. For novice researchers who are interested to develop educational activities to facilitate students' understanding of disability concept, what type of models of disability should be selected? That's a first question. And then a comment, what I am seeing in literature is not consistent in that
There's
regard.
no consistency, yeah.
Also, we appreciate feedback on evaluation tools. It's very hard to find disability-focused assessment tools in the literature. A lot of questions in one.
Sorry.
So why don't I highlight what type of models of disability should be selected? Dr. Smeltzer, could you?
Yeah, I'd like to jump in on that one. There are, you should probably know, there are a number of models of disability. And I think from my perspective, there are two that are particularly valuable in nursing. One of them is the biopsychosocial model of disability, which basically means, we're not just looking at the medical issues, we're looking at the, the community and the environmental issues. We're looking at, quality of life, things of that sort. And then a second one, which is not really a model, but it's something that I think is really important. There was a nurse in the UK, his last name was Goodall. I don't know if he's still alive. He developed a model, he called it a model for disability in nursing, and it's called the interface model. It doesn't have all the pieces of a model, but what it really talks about is where you take the the issues, the health issues that the person is talking about or has, and the nurse intervenes at the intersection of the health issues as well as what that person needs and what that person wants, as well as the social side of things. In contrast to the medical model, which doesn't look at the social pieces, and the social model, which is the one developed by the disability community, but that sort of largely ignores the health issues. So the interface model and the biopsychosocial model both address all of those issues in one. And I think that's really an important thing for us to consider.
Dean Ty has a question, and feel free to raise your hand, by the way.
Mhm.
Thank you. So I hope we can schedule an additional follow-up, because this is such a distinguished panel with so many interesting perspectives and so much to discuss. We don't have time for you to discuss invisible disabilities, but I think that's very, very significant. I wanted to ask your opinion of the difficulty for people with disabilities to become healthcare providers. My previous position, I had the honor of learning from Andrea Dalzell, who was in the program at the time I was dean there. And she became the first nurse in New York to registered nurse in a wheelchair. And she shared publicly at theseatednurse.com her experiences. And it was very challenging for us to have clinicals accept her in a wheelchair. So it was a challenge for her to complete her requirements, even though she's perfectly capable of performing those duties. And she shared that once she became a registered nurse with her BS, it wasn't until the pandemic when she was able to get employment in field, because employers just say, no, we don't want a nurse in a wheelchair. And when the pandemic came, there was such a shortage, they accepted her, and she was actually able to practice finally in her chosen profession. So I wonder if you have any thoughts on that, please.
It's a huge issue, and there are people, in medicine and in nursing who have written that one of the ways in order to address disability in nursing education or in medical education is to have healthcare providers who have disabilities. So it really is an important piece. One of the problems is that sometimes schools, sometimes state boards of nursing use a set of criteria which is outdated and inappropriate in order to determine who should or can be admitted to a nursing program, or who can sit for the for the licensure exam. That's another thing that we need to change. If the licensure piece is keeping folks away, there are a number of people, not a huge number, but there is maybe a small number of people out there who have sort of expertise specifically related to integrating nursing students into curricula, into nursing programs, and are incredible resources, that I would recommend for anybody. It's a very important issue for us.
Thank you, Dr. Smeltzer. Also, nursing being a practice profession, it's not just the school, it's also the clinical site.
Correct.
So trying to find, you could, do the didactic, but trying to find an institution that will accept a student with disabilities, it's extremely challenging.
Yeah, one of my colleagues talks about that issue that you just raised, Maria, this way, and that is, let's not talk about what the student can't do, but let's talk about what the student can do. And I think another piece of that is, and what do they need to do? Do they really all need to work in an ICU? No, they don't. And we need, from the program standpoint, we need to figure out what it is we can do to, get people, into nursing, into the other healthcare professions, so that they can make a difference in, and raise the level for everyone. There's a wonderful video about a nursing student. It's got a terrible name though. It's Open the Door and Get Them a Locker. I believe it's available, YouTube or wherever it is. It's a story of a young woman, and she encountered some of the same issues. People saying, well, how's she ever going to work in an ICU? well, maybe she doesn't want to work in ICU. And it's an excellent resource that I would highly recommend. Yeah, Rhonda, you're absolutely right. It's those technical standards, which were not actually developed for nursing students. They're developed for clinical facilities, and yet schools use them and that's inappropriate.
Maybe time for one more question or comment.
I think I would just like to, thank Mary and Suzanne and Marie for, her leadership. She is the co-project director for the Yucatan grant and, leading, this work for us. And I can say that, we've learned so much already. We have much more to learn, but I do believe that, we can change the face of nursing education one program at a time. And I'm very proud of our faculty for embracing this work and the importance of this work. And I think that one thing that we will do is we will produce nursing providers who are going to start making a difference. Number two, we're going to be able to study what we're doing and what works, and be able to share those strategies of what worked in our curriculum and make our curriculum better. And number three, we'll be able to disseminate through presentations and publications this work to hopefully spread the word that this isn't something nice to do. It's something that we must do. We must do.
Could not agree with you more.
Yeah. So thank you. Dr. Smeltzer, you pointed out that it's not just the disabling condition, but it's quality of life. It's the family, it's the caregiver, and whoever else participates in the care of this person. And Dr. Donahue, you pointed out the fact that there are so many gaps from pediatric, from newborn, all the way to older adults, and that we need the wherewithal to address those gaps. And Dr. Manoval, thank you for spearheading the change in the curriculum at the Linhart School of Nursing. But most of all, I invite anyone who's participating in this program to come along with us as disabled people, as caregivers of disabled people, as healthcare workers. Come along with us. We need your advocacy. We need your voice, because a lot, probably the #1 challenge among people with disabilities, regardless of the disability, is being voiceless. It's not being able to I don't think it's going to remain with me for a long time. The fact that when a disabled person is pregnant, they ask them to terminate the pregnancy just on the grounds of disability. So we learned a lot today. May we apply it to our practice, those of us who are healthcare practitioners, and as well as to our neighbors. Because if you look around, you will see a disabled person next to you. Thank you so much. Thank you so much to everyone who participated. And Sophie, if you have any last words.
I just wanted to, I'm trying to keep up with the comments, which are so grateful for everyone for making time to be with us today. And so grateful to Dr. Smeltzer, Dr. Donahue, and of course, Dr. Manoval and Dr. Charles. This was a terrific panel. And I hope you will also join us for our future CHP Grand Rounds coming up on March 28th on animal-assisted health, and also on April 26th, I believe, on health equity and reproductive justice. So thank you, everyone.
Thank you.